Hello, in this video we're going to look at septation of the heart, and we're going to think about some general principles to begin with, followed by a more detailed look at how the atria are separated, and finishing with a discussion of some congenital heart disorders which are caused by disordered interatrial septation. So let's start off just by thinking about the primitive heart tube and how that is split up into the adult chambers from a very general point of view. And what I'm going to do is draw on the primitive heart tube in the view that we're all quite familiar with by now. So here is our primitive heart tube. Here are the branches coming off of the truncus arteriosus, which are going to feed into the aortic arches. Here is our primitive ventricle. Here is our primitive atrium. And then here are the various veins of the sinus venosus. So the problem that we've got is, how do we go from this very simple organisation, that is of a two-chambered heart which is seen in fishes, to the four-chambered condition which is seen in mammals like us? So the key thing we've got to do is build so-called septa, and the process is known as septation. And these septa will split this simple structure into a four-chambered heart. The first septum that we need to consider is how we're going to separate the primitive atrium from the primitive ventricle. How are we going to create this atrioventricular junction? All right? So what we need is, if you like, to create an atrioventricular septum. Okay? We need to create an atrioventricular septum. And this will enable us to partition the atria from the ventricles. And embedded within the atrioventricular septum, we will find our atrioventricular valves. So we need to form an atrioventricular septum. Next, we need to form an interatrial septum. So we need to form an interatrial septum. And that interatrial septum is going to separate the primitive atrium into a right and a left atrium. Okay, enabling us to separate oxygenated from deoxygenated blood. We also need to create an interventricular septum. So an interventricular septum, whereby we can separate the primitive ventricle into a left and right ventricle. And finally, we also need to separate the outflow, because what we need is the right ventricle going into the pulmonary artery and the left ventricle going into the aorta. So we also need an outflow septum. And in this video, we're going to focus upon the formation of the atrioventricular septum and the interatrial septum. So that's the very basic principles of how we're going to go from this two-chambered primitive heart to a four-chambered advanced heart that we see in adult humans. So let's start off by looking at how the atrioventricular junction, or the atrioventricular canal, is separated. And the important embryological structure that we're going to be looking at the development of is a couple of little bumps of tissue called the endocardial cushions. But first, I need to tell you about the view that we're going to be looking at this developmental process through. And we're going to be using the side view of the heart that we used in the first video when we considered cardiac looping. So just allow me to draw this side view of the heart. So here's our truncus arteriosus with our branches going into the aortic arches. Here is our primitive ventricle, just here. And then you'll remember that the primitive atrium loops up and behind the primitive ventricle. And then here are our veins, like that. Okay, so there's our primitive atrium sitting behind our primitive ventricle, and this narrow waist-like structure is our atrioventricular junction or our atrioventricular canal. And the view that we're going to be looking at this developmental process in is as if we'd chopped off the ventricle, so it's as if we'd removed the ventricle, and we were then looking down onto the atrioventricular canal. So the view that we've got is that view there. Okay? And we're going to be looking at events taking place at the junction between the atrium and the ventricle. So if we look down on this atrioventricular canal, diagrammatically, we see something very, very straightforward, really. A circular, or in this case, a kind of rectangular structure I'm going to draw for you here. Okay, so this is our atrioventricular canal as if we were looking at it through that eye. Okay, and there's the lumen of the AV canal, which I'm going to abbreviate as, let me just rub that out, I'm going to abbreviate this as AVC for atrioventricular canal. AVC. This is the left side, this is the right side, this is the dorsal side or the back, this is the ventral side or the front. And what we're going to see, what I'm going to show you, is the formation of the endocardial cushions, which are going to grow out from the dorsal and ventral aspects of the atrioventricular canal and separate that canal into two halves. So the next stage that we can draw, once again maintaining the orientation that I showed you just now, is we've got our atrioventricular canal just here. And we start to see two little bumps developing within it, just there and there. And these little bumps are called the endocardial cushions. Don't worry about the name. All it means, all it's referring to is two little bumps of tissue growing from the dorsal and ventral aspects of the walls of the atrioventricular canal. These bumps continue to grow. So they continue to grow until they meet. All right? So here we've got the final stage that we're going to draw. So here, once again, looking down upon the atrioventricular canal, and we ultimately get to a point where the endocardial cushions meet together. Okay, so these are the endocardial cushions which have now grown further. And these endocardial cushions separate the atrioventricular canal into left and right halves. So if I remind you which is left and which is right, this region here is ultimately going to contain the mitral valve, and this region here is ultimately going to contain the tricuspid valve. And the endocardial cushions are going to contribute to the separation between the atria and the ventricles and also help to support the valves in place. Now, these endocardial cushions are only separating the atrioventricular junction. However, for the heart to become fully septated, they will need to fuse with the interventricular septum coming up from below and with the interatrial septum coming down from above. So highly diagrammatically, what I'm trying to show you, if we focus on the right-hand side of the page, is that we've got the endocardial cushions, the endocardial cushions which have formed here, and they're going to need to ultimately fuse with the interventricular septum coming up and with the interatrial septum coming down. And once the interatrial, interventricular and endocardial cushions have fused, we will end up with full septation of the heart into a left and a right hand side. So that's the basic idea, and the endocardial cushions are central to it. Now let's look at how the atria are separated from one another in a bit more detail. So we cannot simply separate the atria using a single membrane of tissue, because if you go back to when we talked about fetal shunts, we need to be able to build a one-way valve that's going to carry blood in the direction from right to left. So we need to create this one-way flap valve, which is going to form one of our fetal shunts. So we need something a little bit more complex. What I'm going to do, I'm going to draw this for you in a highly diagrammatic way, and then I'm going to talk you through the sequence of images on the right-hand side. So let's start off just by adding on some basic landmarks. Down at the bottom here of my diagram, these are the endocardial cushions. Remember, we said that they're helping to septate the atrioventricular junction, and that they will need to fuse with the interventricular and interatrial septa. So here we have the endocardial cushions, which I'm just abbreviating to ECCs. And up here at the top, we have what can be thought of as the roof of the primitive atrium. Now, two septa form to divide the atria, and they are named using Latin terminology, but thankfully the Latin is relatively easy to understand. And if you understand what the Latin words mean, you understand the order in which these structures form. So initially, a septum grows down towards the endocardial cushions, and this is the first septum to form. So this septum grows down towards the endocardial cushions, and this is known as septum primum. Okay, septum primum. So septum primum, as its name implies, is the first septum to develop. For your orientation, this side is going to become the left atrium, and this side is going to become the right atrium. Okay? So septum primum is the first septum that forms within the primitive atrium. Associated with septum primum is a hole. Necessarily, as septum primum grows down, it leaves a gap between its free edge and the endocardial cushions. And this first hole is known as ostium primum. Ostium meaning little mouth. Okay, so ostium primum. Sometimes you'll see it called foramen primum. So in this context, ostium and foramen are interchangeable. Now, septum primum continues to grow. And what that means is that ostium primum gets smaller and smaller. So ostium primum gets smaller and smaller and smaller. And if ostium primum were eventually to disappear due to the continued growth of septum primum, we would have a big problem, wouldn't we? Because we would not be able to shunt blood from the right-hand side to the left-hand side, which, as we have said, is absolutely crucial to the normal cardiovascular function of the fetus. So what happens is indeed septum primum continues to grow until it fuses with the endocardial cushions. But then something remarkable happens. And in fact, it's not in order like this in sequence. These things are all happening kind of simultaneously. But what happens is that a new hole appears within septum primum through the process of programmed cell death or apoptosis. So we have a new hole appears within septum primum. Okay? That hole, of course, is called ostium or foramen in some books. And this is the second ostium or foramen to appear. So we call this ostium secundum. Okay, ostium secundum, the second hole to appear. So now we retain the ability to shunt blood from the right atrium to the left atrium, which is very, very important if we are to bypass the fetal lungs. However, there's an issue with this system, and that issue is that blood is able to pass bidirectionally between the atria. And the problem there might be that too much blood is getting to the lungs and hence being wasted because the lungs are not required in the fetus. So what we need to do is to form some kind of one-way valve. And the way we do that is through the growth of septum secundum. So we've already had septum primum, the first septum, but on the right atrial side, we now develop a second septum called septum secundum. And septum secundum grows down like this. And it comes to overlap ostium secundum. So this is septum secundum. And importantly, you'll note that it is overlapping ostium secundum at this point. Now, septum secundum, the free edge of septum secundum is kind of oval shaped, and the hole that is formed at the free edge of septum secundum is called foramen ovale. Okay, so this is foramen ovale. So the situation we now have is in fact a one-way flap valve, if you like. So imagine if the pressure were high in the right atrium, blood would hit this portion of septum primum and then move through this region here and out through ostium secundum. Okay? So we can depict that as an arrow. So in comes the blood, it moves through foramen ovale, through this flap valve, and then into the left-hand side through ostium secundum. Imagine if we tried to go in the opposite direction. If we tried to go in the opposite direction, imagine that pressure is higher in the left atrium than the right, it would force this portion of septum primum against septum secundum, and it would block it off. So if the pressure in the left atrium is higher than the pressure in the right, it would force this portion of septum primum against septum secundum. And indeed, that is what happens at birth. Because at birth, when the baby takes its first breath, then the lungs open up and the pressures within the left atrium increase. And that means that there is pressure pushing this portion of septum primum against septum secundum, fusing together these, okay? And in fusing together the two septa, we fully separate the right and left atria. So this is a very important arrangement indeed. And we're going to look at some of the problems that can occur with this in the next section. But before we do that, let's just take a look at these images on the right-hand side. In blue, we have septum primum, and in green, we have septum secundum. So let's just focus on septum primum in the images to begin with. You can see septum primum growing down, and you can see ostium primum there sitting beneath it, as we said. You can see how septum primum in the second image down has fully fused pretty much with the endocardial cushions, but ostium secundum has now started to form, and it looks a bit like a little sieve-like arrangement with multiple little holes, but they will coalesce together to form ostium secundum. At the same time, septum secundum is growing down, and it will also ultimately grow all the way down towards the endocardial cushions, leaving just this single hole, which is foramen ovale, providing the one-way flap valve from right to left-hand sides. So atrial septation, very, very important indeed. And there are a number of ways in which this process can go wrong. And these are known as atrial septal defects. And essentially, atrial septal defects are caused by either absent or small interatrial septa. So if you imagine, if either septum primum or septum secundum are small, underdeveloped, then that flap valve, which is so important for shunting from the right to the left atrium, will not work effectively. Furthermore, if ostium or foramen secundum is too big, the flap valve won't work. If foramen ovale is too big, the flap valve won't work. So these atrial septation events that we described are crucially important for the normal functioning of the fetus. There's one other thing I just want to mention to you, and this is a very interesting condition called patent foramen ovale. And patent foramen ovale, frequently these congenital heart conditions are seen in children, but patent foramen ovale can be seen in adults and frequently is. And in patent foramen ovale, what has happened is that the septum primum and septum secundum have failed to fuse together after birth. And in that case, what we see is we retain a communication between the right and the left atria. Now, if this communication is small, it may be completely asymptomatic and not show up at all in any of the checks which are done on the child. However, it can manifest in adulthood, say following the formation of a deep venous thrombus. Usually, thrombi which form in the venous system are filtered out by the lungs and can cause a pulmonary embolism. However, in some of these patients with patent foramen ovale, what can happen by sheer bad luck is that the thrombus which formed in the venous system can cross over from the right atrium to the left atrium and thence into the systemic circulation. And this can present as a stroke. Okay? So through this abnormal patent foramen ovale within adults, a thrombus which would normally be filtered out by the lungs can get into the systemic circulation and cause a stroke, a heart attack, or other conditions. So that's one reason why it's always well worth, in a patient who's had a stroke, you listen to their heart, and you may well hear a quiet murmur that could be caused by patent foramen ovale. Or alternatively, of course, you could send them for an echocardiogram to look in more detail. So that's atrial septation, very, very important. The final thing I want to talk to you about is a congenital heart disorder known as hyperplastic left heart syndrome. Essentially, these children are born with just a single ventricle, and there is a large amount of speculation as to the cause of this. But you can think of it essentially as being caused by having too narrow a passageway between the right and left atria. And it may be that the primary cause of this, although this has not been definitively established, is that ostium secundum is too small. So what would the consequences of this be if ostium secundum were too small? Well, what we would see would be inadequate flow of blood from the right atrium to the left atrium, resulting in the left side of the heart receiving nowhere near as much blood as it needs. Now, in the body, we have this kind of rule called use it or lose it, so to speak, which is that if a part of the body is not worked hard, it won't tend to develop as big as it could. And this applies to the consequences of a small foramen secundum. Because if not enough blood is getting to the left side, then we will see a small left atrium and a small left ventricle. And that is indeed what we see in hyperplastic left heart. In hyperplastic left heart, because not enough blood has been delivered to the left side, the left atrium and particularly the left ventricle are extremely small. So small as to not be doing any useful work. And the consequence of that is that the right ventricle becomes the sole ventricle supplying the entire body, both systemic and pulmonary circuits. So in hyperplastic left heart, we see a very small aorta, but a grossly enlarged pulmonary trunk. And furthermore, and very interestingly, we see that ductus arteriosus is large and is in fact the main conduit whereby blood is getting to the aorta and the rest of the body. So we've got this very interesting situation where ductus arteriosus is providing the bulk of the blood to the body. Now, if a child with this is diagnosed prenatally with this condition, it's very important to take certain steps before you ultimately repair it. And these are pharmacological steps whereby you need to prevent the ductus arteriosus from closing. and you can do this with certain drugs that you'll probably learn about. But you need to pharmacologically prevent ductus arteriosus from closing in these children, because if it does close, as is the normal case after birth, then the systemic circuit will be completely deprived of its blood supply coming from the right ventricle, and that child would die if that happened. So you need to prevent the ductus from closing. So thank you very much for listening, and I hope that this was beneficial to you.